Mike, I'm going to hand it over to you if you want to
No, I think we should probably
kick off.
start.
Yep, please go ahead.
Okay, good. So welcome back, everyone. It's been a fascinating discussion so far, and we'll try and pick up some of those questions and comments later in the discussion at the end. But for now, in this session, I want to hand over to Sassy Molyneux and Maureen Kelly, who you all know very well. And I think Sassy's going to go first. So Sassy, over to you.
Thanks, Mike. So Maureen and I are going to share an approach that we've been developing with others to evolve approaches really to provide context-sensitive responses to the vulnerabilities that we encounter over the course of our research activities. And we're giving this presentation, as usual, on behalf of many people, but we wanted to make a special note of all of the people who are listed on this first slide here. And really delighted that Rita, Koi, Jay, and Vicky are all in this meeting. So the approach that we've evolved primarily through the chain case study work, which is one of the 2 case studies for REACH in Kenya. And Rita and I talked about chain yesterday, but the key points are that this is an observational cohort study focused on 500 children in each of 9 hospital sites in LMICs. And the point we didn't make yesterday, but that's important, is that 1/3 of those children in each hospital site were severely undernourished, 1/3 were undernourished, and 1/3 had no undernutrition at all. And the main objective of this cohort study was to identify the key influences on very high levels of child mortality post-discharge from hospital, and especially among undernourished children. And the idea of the cohort was to identify actionable intervention points that could be tested in future research at many different levels. But given the hospital focus and the makeup of a large part of the team, there was a big focus on the child and biomedical interventions, but also wanting to pay attention to the child being part of a wider family, part of a wider homestead, community, and the health system. So looking at vulnerabilities at these different levels to poor outcomes that might be reduced through interventions, agency and resilience among individuals and in the system in terms of responsiveness to families and to communities, resilience and system responsiveness that can be strengthened through interventions. So very important with a study like this involving such vulnerable groups is it important to do the research in the first place? And the arguments for this is that there are unfortunately a lot of well-meaning but actually ineffective humanitarian programs aimed at supporting with undernutrition. And these programs cost a lot of money, and that money could arguably be much better used. And these interventions are often based on an inadequate understanding of influences on mortality, and that there's a real need for research to begin to fill these gaps. So Rita and I talked yesterday about how this cohort study was embedded in and observes normal pediatric admission and care. And so this diagram that we showed yesterday illustrates in red the additional activities that happened as part of the chain cohort work. So basically additional sampling, usually when normal clinical samples were being taken for research, and questions, this happening during their hospital admission and post-hospital discharge, the questions and the sampling. Post-hospital discharge, this was organized through 3 follow-ups back to the hospital within the 6-month period post-discharge. And because these follow-ups were being conducted for research purposes, the fare was covered by the research group for them to come to the hospital. Social science and ethics work was integrated into the cohort work in order to help inform interventions, make sure they're as locally appropriate and relevant as possible, and to identify ethical dilemmas and responsibilities in conducting this sort of work. So the quantitative element of the social science included asking questions of families for all children across the whole cohort to try to work out socioeconomic behavioural determinants of poor outcomes. And the qualitative work was focused on 4 sites, and here we were trying to gather family and staff priorities and perspectives in more depth about vulnerabilities, about potential interventions, and also about ethics, dilemmas and responses, with Khalifi being the focus, especially for that last set of work. And we had intended and ensured from the beginning that the approach to doing the ethics was embedded into the whole chain programme of work. So Maureen was a formal ethics advisor on chain, and she offered, with many of us, advice during the design and throughout the conduct of the study. And we were keen to make sure that that advice incorporated learning from interviews and observations that were part of the work with research team members and the interviews in homes and communities and our observations. So we wanted to be able to, and planned from the outset, to discuss what was coming up from those interviews and observations, think about any action needed, and make sure that that learning was shared across the different sites. So Rita and I talked yesterday about some of the family stories that we heard, and that the treatment-seeking stories and pathways revealed really multiple layered vulnerabilities among many family members and many families, and also agency that was constrained often by that situation that families were in, and also by broader structural drivers. We showed, we think, that the hospitalization, the research encounters were only ever a small part of this much bigger story, and feeding into it and interplaying with it in different ways. Rita highlighted that overall, most of the families found the encounter and the involvement in research very positive. But throughout the presentation yesterday, we were highlighting that the encounters for frontline staff members presented them with many dilemmas. So they were hearing about, in their interactions with families, lots of needs, really high expectations often, some fears, and this presented them with many ethical dilemmas that we began to share yesterday. As soon as we began doing the research and talking to frontline staff, we began to hear about these dilemmas, and we experienced them as social science team members ourselves as well. And I just wanted to spend some time to give you some illustrations of the kinds of dilemmas that were shared with us and that we heard about. So looking at the bubbles in this diagram, a couple of illustrations, different ones, on dilemmas associated with consent. So as frontline field workers working in the hospital mentioned, sometimes you give a parent a consent, and then at the end of the day, the way they give you the feedback or the way they respond, you ask yourself, did this parent really understand that this is just a study, that she can either choose to participate or not? Because you gave someone a consent, and then at the end she tells you, it's okay, because I just want my child to get better. You see, so you're left wondering, should I consider this refusal or is it acceptance? A different type of dilemma after consent has been given. If by any chance this child, maybe because of the ongoing clinical problem, the child deteriorates, usually the first blame is research as a cause of the deterioration. Yeah, even if you go and revise to explain that this is just the ongoing clinical problem, for them, they will be attached to the idea that my child was in research, has been bled when admitted, the child has been bled again right now, and my child has deteriorated. So what we're seeing there is a challenge, even just with those two small quotes, of needing to be reassuring that this is only an observational study, but also wanting to promote understanding for a range of different reasons. Another issue that came up a lot right from the beginning was compensation levels that were being given for those follow-up clinic visits. And there were slightly different slightly different levels of compensation being given for similar studies involving similar participants. And this was causing a real challenge for frontline staff who found it really difficult to justify the difference. It was less than $1, the difference, but it really mattered for family members. And this was linked to this being what was agreed and approved in ethics approval forms, and this being quite difficult to change. It can take about 4 or 6 months to make an amendment to a compensation level and a consent in research protocol. Just to give some illustrations of some of the wider household or system problems revealed by research questions and clinical investigations. So, for example, a participant, as part of their clinical care, is referred for expensive tests or procedures and they can't afford it. And Chain, the hospital and the institution doesn't cover these costs. You still require to collect information from this participant on a follow-up visit. How do you ignore their plight and proceed with data collection and samples? Or participants who score badly on the depression score, this is a PHQ-9 form. How far should we intervene beyond directing them to counsellors that are there in the hospital? Will they even go to the counsellors? How busy are our counsellors, and will they really be able to follow up? And then a field worker went to a home for a discharge interview, which happened for all of the cohort children, including SES questions mentioned. Sometimes you even regret asking those questions. Why am I asking these questions? Yet by the time I'm done, I will not have helped in any way. Like a question may ask, in the past week, has anyone gone to bed hungry? The mum responds, that's the norm. At the end, you leave her like that. She tells you, we haven't eaten anything since yesterday up to now. Then you're like, okay, mother, I'm leaving. You switch on your Land Cruiser and leave, but you feel like, why was I asking these questions? Yet I could not chip in, even if it's saving the situation today and tomorrow. And I think one of the most moving things that I was told about directly is a frontline clinician who said to me when they in the hospital asked about some of the socioeconomic situations in household, the mother just looked at him and he said he just saw tears come down her face and he was at a loss of what to do. Sometimes we're just told about situations which are worrying and uncomfortable. So to give an example in some of our social science work, a mother said, I decided to remove the child from the nutrition program because the child was always sick. When the child falls sick, they, the nurses, would reprimand me whenever I'd go to collect the food supplements. They would say that I'm the one who's selling the flour and I don't give the child enough porridge. So I decided to just stop going. So what we can hear with all of these examples, there's so many different examples that we could give, is that the frontline staff are facing really emotionally difficult situations, worrying about what should I do? If I do something, where does my responsibility end? And worrying about other participants, fairness across participants, what implications for the rest of the research team? What about for Chain and Chain's important learning? Will it impact on that? And then other studies in a research institution and the hospital more widely. So what we often found is that staff members would tell us that they would reach into their own pockets to assist, often discreetly. And in so doing, they would often mention this as like confessing or admitting to helping out in some way. So as one field worker explained, the field worker said, I told the mother, Kemri does not allow me to give out money. So I haven't given you this money as a Kemri staff member. It's like an offering, like the way you give out offerings in a mosque. That's how I'm giving it to you. So that it gets clearly in her head that it's not from Kemri, but that it's a blessing. And so the worry there is about trying not to break institutional rules around benefit sharing and around proposal agreements on benefits, for instance. So as we started to hear about and experience so many of these issues ourselves, we knew that we needed to fill a gap of practical ethics support and guidance to dealing with these types of dilemmas as and when they arose. So what we slowly evolved, and this is taking on almost some of the debriefs that Coy mentioned earlier, taking them forwards into what we began to call ethics reflection sessions. And we set up these meetings that lasted several hours, usually. We deliberately made sure they involved lots of the different team members of different experience and knowledge and different seniority. And the idea was to try and have a really relaxed and judgment-free setting where everybody, and especially the people confronting these dilemmas, were feeling able to share what they were going through, moments of discomfort where they weren't sure what the right thing was to do morally or ethically. It wasn't easy or straightforward to set up these safe spaces. It was a lot of work to make sure that we did it in ways that were appropriate. And I think that quote that I gave you where people talk about secretly or discreetly giving something is just one illustration of how there were real concerns and hesitations around sharing some of these experiences by frontline staff with their seniors. And I think this relates to some of the presentations we've already had today as well. There were concerns that it might look like they don't know what they're doing, or they might be judged to somehow not be professional enough if they're not handling this, and being worried that they might be going against study or institutional rules. So there were a whole range of approaches that we used to try to set up these spaces. Some of them included, we had at one point a tool that people could fill in anonymously to feed in any particular issue that they wanted raised and discussed at the meetings. We had quite careful discussions with senior staff in Chain before the first one of these ethics reflection sessions. We knew that they would be very supportive of hearing about these issues, and we wanted to make sure that that was clear in the way that they responded to the issues being raised in those first meetings. And in those first meetings, we also shared some of our own experiences as social scientists, research and part of the background responsibilities to act. We would think also about how much capacity there is for the person to be helped, for the person enacting a response to be harmed, who the best person or institution is to help for each situation, and the implications of actions, including unintended consequences. And then the hexagons in this diagram illustrate what we would think about in terms of types of action. So in some cases, there was nothing specific that could actually be done, but at least the dilemma has been shared and recognized across the team. And sometimes there was a need for individual counseling or support that could be organized separately from these meetings for individuals. Sometimes there was an immediate agreement around the table about how something could be handled in future and a shared learning on that. Sometimes there are implications at a study level, so we'd have to change exactly how the benefits were implemented or the consent processes were being implemented. And sometimes that required the proposal to be amended and sent back to national ethics approval and science approval, which of course is time consuming. But just to give you some of the illustrations of how the dilemmas we discussed began to be categorized. So in terms of urgency and seriousness, we categorized as urgent this issue of taking time, and I mentioned this yesterday, in discharge interviews in homes, and also as part of that lengthy process, asking quite difficult questions about socioeconomic status. Also, and I haven't mentioned this yet, but staff were very concerned early on about the need, before they'd conducted any, to be conducting verbal autopsies for children who died at home. We saw this as needing immediate, timely action. Serious issues included those around suicidal feelings being raised in PHQ-9 questions, and reports of physical violence in homes that we came across sometimes. And less urgent or serious, as an example, is parents being put off joining the study because of the volumes of blood. In terms of relatedness to the research, examples of types of dilemmas that wouldn't have risen at all if it wasn't for the study design or its implementation. those differences in compensation levels between similar patients, that needed to be resolved, and resolved fast, and was caused by the research itself and the institutional policies and their application nationally. And so we wanted to act on that fast. Also, the emotional impact of being asked to answer verbal autopsy questions wouldn't have happened if it wasn't for the research. So we're keen also to act on that at multiple levels, which we did. Some research was, some dilemmas were increased by the procedures, or even by explaining those procedures. So for example, around the anxiety for blood samples, even though many of these blood samples were taken actually primarily for clinical care. And some were revealed by the study procedures, but not necessarily caused or increased by them. For example, this SES questions, and also the clinical checkups that required or suggested the need for referrals that couldn't be covered by the family study team or wider institution. So we just wanted to share this approach of how we worked with the dilemmas that were being raised, and sought to actually take them seriously and understand them and unpack them. We felt that there were many opportunities from this approach. It offered, and people talked about it, giving psychological relief to simply share them. There were many actions that were actually possible in the short and longer term, and it was appreciated that there was this action, that issues were heard and they were taken seriously across research team hierarchies. And the auxiliary care plans, the consent processes and SOPs and so on were all brought to life through the discussions in these ethics reflection sessions. But they weren't without their challenges. They take time and expertise, not only in ethics and of course local culture and embeddedness, but also a really deep understanding of the institutional policy practice and politics and how to make changes. It was absolutely key that the PIs on this research project were really keen on this approach, on learning from frontline staff, and took seriously the issues that were raised and responded to them. And you know, that's an essential starting point. In terms of beyond the actions that required intervention beyond the team itself, sometimes it was difficult to influence these, and sometimes they took a long time. And sometimes, you know, they still haven't yet had a chance to be acted on because they require institutional change. And although many of the emotional issues were positive in terms of clinicians seeing the vulnerability of many of their participants, some of these vulnerabilities were unsolvable in the short term at the very least. And there's this problem always of where does responsibility end? So we were thinking and have always taken the approach that this is only one part of what might be done to support staff post-approval. Obviously, it's absolutely key that the research proposal itself is a good ethical design, and that doesn't always mean RCTs. The approach that we adopted was layered on top of, for example, participatory training in emotional management and communication, and we've begun to share some of the materials on this website here, but we'd really love to hear about other support processes and to get your insights on this. So I'll hand over to Maureen now.
Thank you, Sassy. So as we're starting to share some of these approaches and tools out of reach, and in this case, out of the work with the team in Kalifi, it's occurred to us there's a huge demand for support in this post-ethics approval space. And so we wanted to be really honest about what it took to put this in place. And as we've mentioned, the heart of all of this work that was revealed by, by 4 years of partnership with scientists across these different sites is that the frontline researchers are the heart of studies like CHAIN. And any effort to improve practical research ethics support ought to be focused on their experiences. And as we'll see in the film toward the end of today, they're a wealth of knowledge and understanding of the context in which these studies are happening. So we just wanted to underscore the importance of that focus. If you had to prioritize as an institution in terms of funding, putting something in place that really is providing the debrief support, emotional support for the frontline staff is so critical. And as Sassy said, it goes beyond just the sort of research ethics component and includes other structural issues that come to light, which aren't necessarily thought of in terms of research ethics, which are equal pay, being on very insecure contracts. Right now in COVID, a lot of studies are suspended, and people may not appreciate that the first sacrifice tends to be the frontline staff who can't go out and collect data during the pandemic. So it can be quite a fragile role, and these sorts of things that obviously went beyond the research ethics issues of this particular study were nonetheless revealed and are really critical to think seriously about. Next slide, please, Sass. Next slide, thanks. So what was the foundation that made this possible? Sassy mentioned a few things, and I'd say this was at the top, which was that Jaya Barkley and Judd Walson, the co-PIs of CHAIN, invited us in at the outset. And there's an increasing practice of inviting one ethics expert to be part of a study, typically when the proposal's going in, to strengthen the study. And then, to be honest, we never hear from them again until they need an ethics report. And this was not the case with CHAIN. We were brought in at the beginning and developed a really rich collaboration with them that was linked to their social science. So they had a separate commitment to building social science within their study that was independent of this additional ethics work. So it was quite remarkable. It's not typical, and we wanted to just say a little bit about what it required. Sassy mentioned the importance of the local capacity in social science expertise, research ethics expertise, and maybe Sassy, Mike Parker, Vicky Marsh, Pek Young, and Janet can speak to this during discussion. But as I mentioned yesterday, all of this was made possible because it was built on this network of research ethics capacity across these countries and institutions that have been built up for nearly a decade. So there's quite a lot of research ethics support and capacity and expertise locally. Time was huge. So Sassy also mentioned, I really wanted to underscore the amount of time that it takes to build in research ethics reflection. You've got extraordinary pressure and timelines on a lot of these clinical studies, and pressures from the funders as well. So the scientists are under a lot of pressure to get the results out quickly, but there's also an ethical imperative to move quickly on the science and not delay it when the science and the evidence is hopefully directed toward really severe vulnerabilities, health vulnerabilities. So holding it up with unnecessary ethical scrutiny actually is a serious ethical concern. So building that time in for the ethics reflection also has to be responsive to the science. So I would say on our part, on the part of sort of ethicists involved in this, you need to really understand the study and understand the need for it and understand the context. And I think that can only really be done locally with the expertise in that site with people who are really embedded. The other aspect of this is trust and credibility. So as Sassy mentioned, it was critical that these ethics reflections were led by people like Sassy and Johnston Tahiri, who normally we give this presentation with Johnston, and he wasn't able to join us. But to have leadership and mid-level leadership and project managers involved and leading these discussions is so critical, because they're in the political institution. They have the institutional understanding and memory, and they can really affect change. The critical part of this is that you're useful, that you are actually solving problems and not just raising questions. So it needed to be very practically focused, and in order to find solutions, you've got to be situated within the institution and embedded in these important ways. Next slide, please, Sassy. The last point we wanted to end on to lead into discussion was really this idea that there are deep structural issues that any project or individual trial just cannot touch. And these were some of the, I would say this was the biggest ethical quandary that came out of all of our sites and all of our projects, is that yes, you can build ethics reflection and an ethics support, but in the end, we've got to send this deeper question back up to funders, back up to institutional leadership, back up to governments, international organizations, and say, you know, we are encountering on the front lines of research inordinate structural injustice, and these are the drivers of health and diseases, poverty, and our frontline researchers are the ones that are encountering them and the ones that feel they need to respond. But it feels as though the response needs to be institutional. You know, these are bigger problems than any one field worker can tackle, and yet they're the ones who are facing it. So there is this just very fundamental disconnect here in terms of these deeper social justice issues that we wanted to raise. Next slide, please. We just wanted to end by thanking the whole chain team who's here in Malawi. They have been so welcoming and so open to really incorporating these discussions, including our ethics and social science team in all of their meetings, putting up with naive questions about the science. And it's been a wonderful experience for us as well to learn from them. And I hope we continue to work with them in the future. So thanks very much to all of them. Thanks, I'll turn it over to our sponsors, many, but especially Wellcome Trust and Bill and Melinda Gates Foundation, who supported both the social science and the ethics in this work. Thank you.
Great, thanks very much, Sassy and Maureen, for a fantastic presentation, which really raises some in addition to the issues relating to vulnerability, also raises important issues, I think, about your own place in this project and how these questions of vulnerability relate to the kind of things that we worry about. So what I want to do now, we've got about half an hour, just under half an hour for questions. I want to sort of start off by seeing if there are questions on this presentation, and then open up possibly to think about the project more generally, or the presentations more broadly, and think about what the implications of this might be for practice or for research ethics governance. So first of all, any questions? Anyone like to chip in on questions for Sassy and Vicky, Sassy or Maureen? Sorry, I saw your hand go up there, Vicky. I wondered if was that just a clap, or did you have a question to ask?
No, it was just a thumbs up.
All right.
Yes.
So we got a couple now. So Caroline and Jay. So Caroline first.
Thanks. I mean, absolutely brilliant. I mean, I think that the whole 2 days for me have been amazing. I think it's been, yeah, really, really interesting stuff. One of the things that I'm quite interested in is the fact that the biological vulnerability seems to have disappeared. So because this is about vulnerability, and I know that the biological vulnerability is sort of on the more clinical side, but I'm just wondering, the reflections around quite a lot of these sick children, I know particularly in chain households, are not, you know, the whole household is not necessarily initially potentially a problem, and there might be other children in the household who don't have these problems. So, and I think came across in several of those quotes about the mother saying, the father's blaming me for this, but actually it's this child. And, you know, you come across this quite often. Mothers don't understand why this is happening to this child. So I'm just wondering if there's been much reflection on the intersectionality between the social structural and the biological, and what sort of questions that raises, both in terms of research and in terms of sort of ethical dilemmas in conducting that research. over. I'm not sure if I've been very clear.
No, that was clear, thanks. So who wants to?
I could have a start at chipping into responding to that question, but I think Jay might want to take it up, because I think, Caroline, that was a big part of the design of the study, was to be able to look at exactly that, the interplay between the biological and the other types of vulnerability. So maybe I should just hand over to you, Jay, on that.
Yeah, that's interesting, because actually I had a very similar question to Caroline, because if I'll sort of come back to the sort of original objective of sort of looking at, what are the mechanisms underlying mortality when we apply the treatment guidelines and do everything, and still lots of children die. This idea, can you tease, what markers are there that can tease out, this child has a problem? And a lot of the children, some of the children do have underlying medical problems, because those problems are totally outside, what's written in what are fairly basic guidelines, and they refers back to the comments you made earlier about, children who are going to need some special scan or some special investigation, and they're likely, they don't happen because they're not covered by the hospital, and the family may not be able to afford it. And I guess there's a very strong link between the biological and the social, in the sense that, mother will be blamed, or we will come along and say, oh yeah, this is a poor household, they've got all these problems, whereas in fact the problem is a specific medical problem with the child. And I think that coming back, we're aiming to try and identify a lot of those problems through a lot of ongoing sort of laboratory-based biological work. But I think that the key thing that we would like to know from the sort of close interaction that the social science team had is sort of, how the team would classify the child. Is this a child whose problems, are largely contributed to by a very challenging situation in which the family or the mother are living and coping, or not, and sort of try and balance those out. But I don't think we don't have the biological data through yet, but I think it's a really important question. And I just wanted to make another comment, which was that one of my sort of big personal takeaways from the ethics reflection sessions was that actually a lot of things could have been solved, were solved eventually, but could have been perhaps solved earlier, just through, enhanced communication. So, field workers in a situation where they didn't know what to do, have a sort of easy sort of line of communication by phone, SMS, or whatever with somebody. And likewise, communications, from the project to the institution, and from the institution to the sort of national and international ethical boards. And I wonder whether, if we're thinking about future projects, whether we kind of try and build these lines of communication into the design of the project, because I think they would massively improve the data collection, as well as being having a system for immediately addressing sort of issues that frontline workers face. So my big takeaway was about communication. I think there were some examples where field workers were wondering whether the child did have a medical problem and weren't quite sure what to do about that medical problem, or the mother had been told by somebody, perhaps not in the chain team, but by somebody else, that there probably was a medical problem and wasn't, either couldn't afford or wasn't sure what to do. So I think, the two are kind of closely interlinked.
Maureen or Sassy, do you have anything to add to that or response?
I think not to add to that response, and I'm seeing some other hands up that I'm keen to hear from, but I think, yes, that basic communication structure and making sure that's in place and supported with good, with an ability for people to raise the issues and feel safe to do so is absolutely key and needs to be built and right from the outset.
Brilliant, thanks. So I've got 3 people in line now. So Holly first, Primus, and then Sally. So Holly.
Hi there. Thank you, everyone, for this great presentations and discussions. really quick, and maybe this is more food for thought than for comment right now. So one, right, you, Maureen, and Sassy are a finite resource, and so it wouldn't be possible, though perhaps ideal, to have you embedded in every project where these issues might come up. So two things. One is whether there might be particular projects where having this approach is especially important, and or if there's a way to create something that teams could use as a way to facilitate conversation that doesn't require a level of expertise, and maybe that would be too challenging, but those are my thoughts. Thank you.
That seems an important point. I wonder, Maureen, if you had any thoughts about that.
I think that the resource question is really important to think about. And again, just to underscore, there a lot was invested in Kimri's social science and research ethics team. And I don't know if Sassy and Vicky want to say more about that. And it's important to acknowledge that that's jobs, and social science grants and research ethics grants that make that possible. So it's partly about expertise, but it's also partly about seeing this as an ongoing part of research infrastructure that's really valuable and building it in as opposed to flying it in. I think I'll just see if Sass and Vicky want to say anything about that aspect, but agree with the communication point as well. It's really critical.
Yeah, I was just thinking that, I think ideally being able to build in this expertise to support in large research institutions, I think is helpful. But just to go back to also, I think Nathando's and Koi's points, that really good debrief sessions and just allowing people to raise issues and to be able to air them and for different team members to become aware of them, I think is also really important to encourage alongside that. So almost not to be so put off by how scary they are or how much expertise is needed to not actually do them. And I think it is probably, in fact, we found these types of fora useful even for very different types of research, but I think it might be possible to identify studies involving particularly vulnerable groups where there's an extra need, I think, to bring in the expertise and support processes. And I think COVID has shown us that more is possible online to bring in expertise from perhaps other research centres or from colleagues in other institutions than we were maybe aware of before. So it could be that could be brought in.
Thanks very much, Sassy. So what to take now, and then I'd quite like people to think about the overall implications of REACH as a project, given what you've heard, for thinking about research ethics or for change clinical practice. We haven't got much time left, but it's good to get some thoughts at least on that. But first of all, I want to, Primus, do you want to ask your question?
Yes, thanks, Mike. And thanks, Sassy and Maureen, for the wonderful presentation. I have two questions. One is focused on how can we carry these findings and engage with funders to think about this in projects. And I would keen to get your experiences. Was it easy to get support for such initiatives within the REACH project and the CHAIN project as well? And then the second is how can we move this towards having some sort of ethical guidelines, perhaps to protect the welfare of researchers, especially frontline researchers. Yeah, because we know most of the guidelines are focused on the research participants. Is it time now to spend more time to really think about the welfare of research staff as well involved in such projects? Over.
Thanks, Primus. Who wants to take one or other of those?
Do you want to speak to the funding issues. Sassy.
With respect to funders and how we can encourage funders to support this more, I'd be really keen to hear from people who are closer to the funding end. We had the privilege with Reach, with having nice funding to do this research and to give us that space, and also for the PIs to give that space, as it were, within their projects and to support that with their funding. So I'd be really, I think we should encourage funding to be given to support processes like this, and that funders should look to support that. The other one about guidance, I do think that between us all and others on this call, we could perhaps just draw on some of our experiences and on the experiences of frontline staff and begin to pull together at least some initial thoughts about processes that might be helpful.
Thanks. In the interest of time, I'll get Sally to ask her question now. Sally.
Hi, thanks very much, and I've really enjoyed the discussions and really nice to connect with people again. And I had 2 points. So the first is around safeguarding. And I think there's a lot of parallels and synergies between discussions around safeguarding and around ethics in terms of ongoing processes linked to relational vulnerabilities. In our Arise hub, which focuses on accountability and well-being in informal settlements, also known as slums, in Kenya, Sierra Leone, India, and Bangladesh. We've set up processes for safeguarding that link to many of the debates, and I'll put some resources in the chat. But it seems to me that there are strategic parallels, and what we have in the Arise hub is safeguarding leads from each of the different institutions, and we come together for monthly check-ins to share experiences. It works as a sort of supportive space, a debriefing, a sharing, and we found that COVID-19 is amplifying safeguarding concerns on multiple levels, and we're having to think creatively about that. And I wanted to learn more about the safe spaces that you've been using and whether they are context specific, site specific, or whether they bring in multiple voices and perspectives. In our case, our check-ins are across all the different contexts, and so we do a lot of sharing and learning there. And I'll share some resources, but in terms of thinking about funding and getting funding, I think safeguarding is an area that funders are increasingly looking at, and is a way to find additional budgets for support, for counselling, for dealing with relational issues that emerge. And then my second point, which is maybe slightly different, is just in terms of the chain study and thinking about severe malnutrition. In Liverpool, we have a direct solidarity link with a hospital in Sana'a, and we originally had research, but since 6 years of war in Yemen, we haven't been able to get money for research, so we've moved to a solidarity fundraising model. There's a really big, strong Yemeni community in Liverpool, and there's lots of challenges in terms of how best to support in terms of ethics and safeguarding issues. So for example, I'm sent photos of children who are 12 years old, weighing 12 kilograms, and we have permission to use them, but should we use them? They're incredibly distressing images. So I'd welcome support on that in terms of how we think it through. And again, I'll put information in the chat about that. Thank you.
Brilliant. Thanks very much, Sally. Any immediate thoughts, Maureen or Sassy?
I'm happy to chime in on the safeguarding question, Sally, and would love to see the resources from your group. And Busi, if you're still on, I wonder if you might chime in as well. So Ari, just to use as an example, has a safeguarding mechanism and office built in for children encountered in the context of research. But one of the things that we found was that, and Busi and Janet mentioned this morning, there is this kind of bridge to nowhere, right? There's a mechanism in place, there's clearly an institutional commitment, but the services are not there. The services are overwhelmed and these young girls are queuing up, and the frontline researchers are feeling anguish over just the process of referral and trying to follow up and find out if the young girl did connect with services. So the reality, while it's, I think, really important that we're starting to see this level of international awareness of the importance of safeguarding, particularly in development research. And I'm on the group that's been advising in the UK on this. It's not yet dealing with the reality of the lack of infrastructure and services in the countries where the research is taking place. So again, just to come back to this theme that we've sort of been hitting on in a variety of different ways, it's important that the shift is happening, but we need to look at the reality of the intersection between the front lines of research where the encounters of safeguarding, for example, are taking place, and the reality of health systems and social systems that can't really take on those participants or patients or referrals. So there is this institutional structural question that I think we need to tackle with. Busi, I don't know if you want to chime in on that. I know it came up quite a lot in your data.
No, I think you articulated it very well. So the big challenge really is that even ARI has a child protection unit, but we refer to government services. So the backlog would still apply in terms of what services the government can provide. And what we found is the issue of working around relationships, because the government staff may feel that ARI has this entitlement because they are doing research, so they can't prioritize ARI over their other many obligations and responsibilities. So that's what I would add.
Thanks. So we've literally got about 6-7 minutes. No, yeah, that's between now and when we can show the film. Maureen wanted me to ask you and to sort of, in a way, step back now, sort of bird's eye view of the project as a whole. Everything you've heard over the last 2 days, these amazing talks, and to think, any sort of initial thoughts or any comments on what you think some of the implications of this work might be. Let me just pick one of two for thinking about research ethics. So is there other big picture messages that come out of this that you'd like to convey? I was just wondering whether either Catherine, right, you might have something to say about that, or Florencia. Any sort of just immediate thoughts?
Florencia, I don't know if you want to go first.
Why don't you go first, Catherine, because you've got the microphone open.
Oh, okay. I think one of the things that's been striking me, it's been an absolutely fascinating 2 days in terms of just the richness of all the data and the reflection. And I think for me, that's why you've asked me, I always think that the next step is how can we make a difference? How can we actually change things? Hence some of my comments in the chat about how could some of this understanding feed better through into the kind of systems that we have in place to support ethical research. And the role of funders in particular, seems to me to be absolutely key here. So I think the two things that immediately sort of came to mind over the last couple of hours. One was picking up Pakyon's comment in the chat about going beyond academic papers, because I think how we make research findings available. I think it's so easy within the research sector to think of papers, but that's not how most policymakers come across issues. And then I think the other thing that really struck me was seeing, I think one of the slides, just seeing the vast number of funders you've actually engaged with in this project. Obviously, you're welcome, and Gates has been a really big one, but many others too. And whether a starting point will be engaging with those particular your own contacts with those funders in pushing some of these questions about how could some of the funding policy change, institutional policy change, to find ways of accounting for these really important ethical dilemmas and the way they need to be addressed. So just some quick thoughts there. Thank you.
Thanks. I'll get a couple of comments and then maybe come back to you, Maureen or Sassy. So Pekion, you had put your hand up, and then I'll come to Florencia after that. That's okay. I assume it's an immediate response to Catherine's point. So Pekion, you go first.
Oh no, I'll wait. I don't want to cut queue. I'll wait. I'll go after Florencia.
Okay, good. We've only got 5 minutes to play with. So okay, Florencia.
Okay. So what really struck me and I was fascinated was this mixed between the theoretical on one part and the practical, and how like what we think theoretically can impact practice and how practice can impact theory. So for example, today I thought it was very interesting, all this presentation by Sassy and Maureen regarding this ethical tool, or the possibility, as we were speaking in the first session, of maybe having a special guideline regarding how to think in certain situations about the frontline researchers and different kinds of research that need this kind of support. So what I learned or I take from here is all that kind of interaction and how fruitful or fertile it is. So that was fascinating for me.
Yeah, thanks, Florencia. So Pekion. You're on mute.
Okay, thank you, Mike, and thank you everyone for such wonderful presentations and session. So, so this is to answer your what next question, Mike, or the so what question. I mean, so we set out to answer the question vulnerable to what and capable of what, right, broadly, and not label people as vulnerable or not vulnerable. So we did really good in-depth case studies in 3 research units that have long-term presence in that location. But we can't do 4 years of empirical ethics work every time we start a new study. So what should we do? What would be useful for to answer this question, vulnerable to what and capable of what, quickly at a new location with a new community? I think this should be one of our, well, at least attempt to answer this question before the end of our project. That's me.
Thanks, and that picks up on Holly's point about scaling up, doesn't it, as well? Okay, so Sheila, you just put your hand up, so keep.
I just wanted to chime in briefly on the issue of what next and funders and thinking in a practical way beyond academia. I think perhaps what we need to do, looking at these findings, is delineate between the issues surrounding vulnerability as a concept in research ethics and these systemic issues of structural vulnerability and structural drivers, which kind of exist independent and outside of the ethics framework, very peculiar to global health research. And if we look at these kinds of systemic issues in a broader way, like using complementary frameworks as human rights or development or humanitarian aid, it might give us the tools to be able to engage funders to view it not just as a research issue, a vulnerability issue, but a broader issue that is part of global health research. So, and in that sense, we could leverage the frameworks from human rights, development, humanitarian aid, and the various frameworks funders use in those sectors to engage these problems. So in that sense, this study really shows that there's 2 issues, the problem of vulnerability, but also the broader problem of researching in global health and the peculiar challenges it brings that perhaps traditional research ethics frameworks cannot really cover or address.
Thanks very much, Sheila. So I think I think that's been a fantastic session. I really, really enjoyed it. What I want to do now maybe is hand over to Maureen if you have any final thoughts in response to that, and then maybe you could introduce Al, because that might be a nice thing to do. Yeah.
Thank you so much, Mike. Sheila, and also Pick Young, I think that point about, next steps and practical tools and how could we inform out of this project and link with others that I think have been doing similar work to come up with a quick assessment for teams that they could use to identify the relevant vulnerabilities and issues in context and put a support system in place, underscoring that it needs to happen, I think, alongside these more systematic kind of capacity building efforts, which have been really long-term. And Welcome Trust is a great example of really decades worth of commitment to some of these sites. I wanted to see just quickly, Mariah, whether you wanted to say anything about some of the practical work that you've done around ancillary care, and just whether this is something that resonates with you.
Yeah, thanks. It's all kind of overwhelming, so I'm just processing everything that I'm hearing about. But in the big picture, it seems to me that there may be like a gradient of like degrees of alienation that frontline researchers feel from overall social efforts to advance the well-being of the population. Like in the SMRU context, it seems like researchers are very well connected and feel like they're part of something that through which their day-to-day activities are just helping people generally. And in other contexts where the structural injustices are so massive and seemingly intractable, it's not as easy for a researcher to feel efficacious, right, in connecting their daily activities with things that really are going to improve the well-being of the people that they're working with. And so, as I said in the chat, I do think there's a tremendous literature in nursing about moral distress and moral resilience that could be really helpful here, pending like better cross-sectoral work at much larger levels to address the actual structural injustices that researchers are not going to be able to deal with directly.
Thank you. Thank you so much. I think that's really helpful, and it's a great segue to a film that Al Davies has been working on for us, which was to try to showcase some of the insights. So going back to this theme that came up both yesterday and today about not just epistemic justice, but valuing the knowledge of local and frontline researchers at all different levels. This includes PIs who are on the front line and appreciate really the situations that they're working in over many, many years and decades in some case. So I'm going to turn it over to Al. This was the spirit behind this project was to put together a film that showcases the voices and insights and sort of what frontline researchers see and how they think about the ethics of research in their context, in their own words, seeing them as a bridge really between the community and research. So Al, I'll turn it over to you in your shed.
Thanks. Thanks, Maureen. Just a few things to this is very much a draft, a working draft. So I'm happy to take on board any comments from anybody who can, yeah, if you've got some ideas for how to improve it. There's quite a few people I should acknowledge before sharing it. I think, first of all, the team in UK, Maureen and Kai in particular, who've really supported. In Thailand, we've had Napat, Supak, Ice, Pek Young, and the CAB, of course, who made those lovely pieces of art. Supak in particular, who I have to say that just looking at some of the photographs that she made, just literally took my breath away. In South Africa, Busi for her voice. In Kenya, Anderson, Gladys, Rita, and Koi, well, Rita's in UK. And also to point out Anderson and Shadrach. Shadrach is the photographer in Kenya, and Shadrach and Anderson facilitated some lovely footage from Kenya. So I'll try and share this.
Thanks, Kai.
We are the frontline research staff. We are the people who gather data, take samples, speak with participants and their families, carry research messages through public engagement events. Some of us are senior in our research institution, some are not so senior. But what makes us similar is that we visit people's homes and sometimes we even land up sharing meals with them. Often, we are working in our own neighborhoods, in our own communities. We listen to people's stories and struggles with interest, concerns, and sometimes sadness, because these are stories that we know very well. We often land up being the face of research in communities and a bridge between researchers and communities. We have a lot of knowledge to share and face many challenges. Many of the challenges we face are to do with what should we do, what are our responsibilities in the community. These are really often difficult ethical or moral problems for us.
Because research happens where diseases are worst, it also often happens where there are other health, social, political, and environmental problems. There may be a drought happening at the time, water shortages, protests around a political election, or staff strikes. In Kenya, communities were facing many of these challenges during our research, including a huge national nurses strike that went on for months.
Here in Mesot, along the Thai-Myanmar border, migrants who join research on malaria and pregnancy are also sometimes living in fear of being discovered if they do not have documents. The roads and bridges may be blocked or become unavailable because of flooding, making it difficult for people to get to a research site, which is also where they come to the clinic for care.
We also see so many difficult journeys. Frontline staff also often have to cross the river in high waters during rainy season.
Despite the challenges communities face, they show strength and are resilient. It is important not to label people as vulnerable or use stereotypes because this can mask their unique needs and inadvertently exclude them from research that could benefit them. For example, labeling adolescents as vulnerable to HIV may stigmatize them and hinder participation in HIV research and result in the development of interventions that exacerbate harms in the name of protecting them. We also see examples of young people's agency. For instance, they portray themselves as proactive and being agents of change in the community whilst managing the HIV disease. So their inclusion in research is important to inform context-relevant research and interventions which support their agency.
It is incredible to see how families and women will work so hard to provide for their family and make difficult journeys to seek care and to participate in research. People sometimes think that young people or women do not have power to make choices in their lives, but they do. There was a young girl, she was 16, and she joined a study because she said she wanted to gain more knowledge, she wanted to learn more.
The biggest ethical challenges we face on the front lines are around wanting to help people directly when research results may not happen quickly and it may not bring benefits for many years. Sometimes I wonder why we're gathering data when what I want to do is provide some care or medicine to this family. I mean, something that is needed today, not tomorrow. I realize it is important to develop better health interventions that will work in our setting. But then I wish we could do more today. More support is needed in responding to ethical challenges in our day-to-day research in our context.
Something that often struck me in my interactions with families in a very low-income area of Nairobi was
how much young mothers went through to try to get their babies treated or to keep them well and restore their health. So they would try to access money, which was often not easy. They would seek advice from various networks on what to do, and this included their in-laws, parents, their neighbors, friends, sometimes negotiating with their own spouses. And all of this was happening in what were very often difficult living environments.
Here in South Africa, HIV has been a serious health burden, and so it remains a major research focus. But there are so many other health and social problems that we see people struggling with. So the question is, how can we work together with communities to make sure research priorities align with what matters most to the community? We need to identify critical points where the challenges and vulnerabilities experienced by the research participants manifest in the research encounter. This will guide and inform research institutions, researchers, and funders to reconsider the nature and scope of the duties of care needs during the research encounter.
People are struggling, but this does not mean that they do not have knowledge to share. They are experts in knowing what they need. They have ideas about what can be done in their own communities. We are excited to embed their voices in research, and they, the communities, want to be active partners in research that directly affects them. Researchers and healthcare staff working on the front line with participants and community members, they are so critical to ensure that the research helps improve the health of communities. Their role is so important to engage with communities. It benefits everyone to make sure that they're supported. We must continue to conduct research with communities for communities to make sure that they get the best evidence-based medical care. Rather than protecting communities from research, we should be protecting communities through research.
Thanks. And the crackling wasn't supposed to be part of it, but never mind.
Thank you so much, Al. Did you want to say a few words? I think it's really fantastic.
Thank you. I just wanted to say it's a bit of a team effort to I think everybody contributed to the script from four parts of the world, and that was quite nice to have that level of kind of communication and input and sharing. We felt it was really important to balance vulnerability with that sense of strength from within and the agency and resilience that came out, and I think that was it was very nice to be able to do that. I think what came across to me as I was kind of sitting, putting the voices together and putting the images together, was that real kind of sense of care that came across. It's really palpable in the voices of the narrators through the story, that the care and the concern they have and they feel and they express for their participants and for their colleagues is really very, very pleasurable thing to put together. Thank you everyone for contributing.
Thank you again, everyone, for chipping in. And you may not realize they've done it just over the last couple of weeks. So on top of the presentations, they've been trying to put this together. We had originally planned the video production pre-COVID, so it was going to be filmed at the sites. And so just a testament to how creative everybody is in trying to pull this together. And Al really is it's astonishing what you can manage to do. So thank you. And we will post the final version on the website so everyone can see the final version and share it. Hopefully, the idea was that it might be something that could be used to prompt a reflection and discussion on research teams with funders, you know, thinking of different ways in which you might use that as a beginning of a discussion locally. So it was really meant to be provocative and try to convey, as Al said, the strength of emotion that you really feel in talking to anyone on the front lines and our team, as you see in the film. Thank you so much, Al. Stay warm. So we're going to wrap up, and I wanted to thank everyone for a really extraordinary 2 days of presentations and discussion, and thank the REACH team for all of the work that you've put in. Like everybody else, they've been juggling family, sick family members, being apart from family members on the other side of the world and not able to see them, you know, juggling work and home life and isolation and all of the things that I think everybody has been dealing with, and doing and continuing on with work with warmth and cheer and lots of support. So I just wanted to say thank you to the team. Maybe we can unmute and clap. And massive thanks to Kai, who nothing seems to.
Oh, yes.
Nothing ever. Just the definition of unflappable, as just evidenced in the last 10 minutes. I don't know what we would do without Kai.
Thanks, Maury.
And thank you to all of you that have joined us for the last 2 days. So all of you are experts in these areas, very experienced, have very dedicated in what you do. And so it's a huge privilege for us to have your time, as I know you're all struggling with the same issues I just raised, and to have, you know, you sit in front of a screen for this amount of time, it really deeply appreciated. And we're hoping that this is more of a conduit and a jumping off point for further discussions, especially when we're allowed to see each other again in person. So we're really open to follow-on projects, meetings. You know, if this links in any way with the work that you all are doing, Sally mentioned safeguarding, other people are working on ancillary care, practical social justice. Florencia has been really, really active and working on ideas of vulnerability in and outside the research context, as is Wendy. So we are really keen, Catherine and policy, you know, the funders who've joined us from Welcome. We're really keen to engage now following on this project, and in any way that interests you, you know, if there are ways that we can collaborate, whether it's papers or projects or support, we'd be really, really eager to do that. So for the time being, we'll stop today's conversation, but hope that it will continue on in many other different forms. And we will follow up with notes from the meeting. Kai told me that yesterday's conversation recording was what, 800 megabytes? So we've got some editing to do to see how we can share the transcript, at least with you, and the notes. And keep an eye out for the website for our publications that we're all feverishly working on. But please do let us know if we can help in any way, support your work, or chip in on areas of connection that you've noticed over the last couple of days. So I think I don't have anything else to say. I wonder if the team has anything else you all want to say.
I think there's lots of thanks going to you, Maureen, from everybody in the chat box for your leadership in this program of work. You've guided us through over the years, brought us all together, and it's been a really fun, inspiring and wonderful group to work with. And I think a big part of that is down to your leadership. So huge thanks for that.
Thank you, Sas. That's kind of you. I think that's it for me. Anyone else? Mike, did you want to say anything?
No, just to echo, Sassy said it all really. I think you've done an amazing job, and obviously all partners have really pulled together. It's been, particularly last year has been very difficult for everyone, but today and yesterday have just been fantastic, and it's a real testament to the work you've all put in and to your leadership, Maureen. So thanks very much.
Thanks so much, Mike. And yeah, we've really built on work that has been done over the last decade or so, and partnerships that have been built up across this group, and between Mike and Sassy, Vicky and Janet and Pik Young in particular across the network. I think if Dina is still on here, Dina also is a huge support in the Global Bioethics Network. So this is just to say it's a real group. This is all a testament to the importance of group projects like this across disciplinary lines. So thank you all.